Welcome everybody today. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. Very excited to welcome you to our 13th session of Innovation Beyond the Edge. This was a program that was conceived in the week following our spring forum being canceled, and kind of pivoting and coming up with some new ideas on delivering value for our members. And I'm going to briefly share my screen right now, just to kind of give a graphic of what we've seen thus far. We've got just a tremendous panel of presenters over this series and season, actually. And like I said, this is the 13th. Our final one for season 1 is going to be on Monday. And really excited to have our presenters today. We obviously, as a society, have been going through some very difficult and really challenging times. But with that, with challenge presents opportunity, and the opportunity to solve problems. And that's really why we're here, creative problem solving. Today, we're going to hear about digital contact tracing at Boston Children's Hospital. And we've got Doctors Daniel Nygren and Jonathan Bickel co-presenting today. I consider Dan a friend. He's one of our board members and just been an amazing friend to Chime. And not sure if everybody on the line knows this, but you've got 2/3 of the world's population of a very raucous group. That's the folks named Jonathan that have a master's degree in bioinformatics. So Dr. Bickel and I, share that together. So been really looking forward to this presentation, and really appreciate the support that Philips is providing, not only as a supporter of this particular session, but a supporter of our overall season. And we really appreciate their support. Without them, this really would not be possible. One of the things that we've been highlighting is creative problem solving, innovation, and it doesn't necessarily involve bright, shiny objects. It doesn't necessarily involve invention. It does involve innovation and creative problem solving. And I can say that with utmost certainty as a recovering patent attorney myself. So with that being said, I want to go over a few logistics here. We've got 3 main parts. The first part is a presentation by our speakers, and then we're going to have a second part, which is virtual roundtable discussions, followed by Q&A with our speakers. So at the end of that virtual roundtable discussion, we will come back for a Q&A and ask that anyone that's got questions to put it into the chat feature, and I'll field those questions in the time that we have remaining. We're also recording this presentation, so this will be saved and stored on the Chime site, so you can go back and review any details once we finish. Discussions within the breakout rooms are not going to be recorded. If you've got any difficulty listening to the audio stream, you can certainly call in. If you do that, please message our host so that the audio and the computer connections can be merged. If that doesn't happen, your phone connection will go into one breakout room and your computer connection will go into another. So please make sure to do that. Also, sorry for all the boilerplate language here, but any folks that have Chime certifications will receive 1 continuing education unit for participating in the presentation and the virtual roundtable discussions. And those will be applied after taking a look at the attendee list. And that's for CHCIO, CFCHE, and CHISL. So with that being said, I'm going to hand it over to Denis Friedman with Philips. Denis is the market leader and for monitoring and analytics at Philips Healthcare. She leads innovation through that component, and really excited to have her as well as Philips support. So Denis, if you can take it away.
I sure can, and thanks, Jonathan. I'm really glad to join everyone today for Innovation Beyond the Edge session. And I'm very pleased, for those of you who are not familiar with Philips, we are a global organization focused at high priority innovation on health solutions that span the care continuum from healthy living, prevention, diagnosis, treatment through home care. I also want to thank Chime for their continued hosting and priority on important topics that are relevant today for our community. And a final thank you to all of the healthcare professionals on the call today for your leadership and personal sacrifices through the COVID pandemic. Our hearts go out to you and the patients that you serve. It's my pleasure to introduce our two speakers from Boston Children's Hospital today, Dr. Dan Nygren, Senior Vice President and Chief Information Officer, and Jonathan Bickel, MD, also Senior Director of Clinical Health Record and Business Intelligence. Together, these two incredible individuals bring a combined 35 years of medical and IT expertise and experience specifically with Boston Children's Hospital, which many of us know are U.S. News and World Report #1 children's hospital in the nation 6 years in a row. For over 150 years, Boston's Children's Hospital has held a vision to advance pediatric care worldwide by providing the highest quality of healthcare, leading the way in research and discovery, educating the next generation of leaders in healthcare, and enhancing the health and well-being of the children and families in its local community. Today, we can see their commitment to advancing care in action by learning about one of their newest innovative efforts, digital contact tracing at Boston Children's Hospital. With that, Dan and Jonathan, I'll pass it over to you.
Thanks, Denise. Geez, we're going to need to get you on the payroll, I think. That was wonderful. Thank you. And thanks, Jonathan, also for the intro. So it's great to see lots of old friends and familiar names on the list of attendees. Because we've only got a relatively short amount of time, we're going to jump right into it today. You're only going to be hearing from me just for a little bit, and I'm going to hand it to the real guy who knows what he's talking about when it comes to this stuff, and that's John Bickel. So just first to step back for a second, what are we talking about here in terms of big picture with respect to contact tracing? Obviously, contact tracing is important to be able to contain the spread of COVID-19 and really any infectious disease. This is not a new concept. It's been around for as long as we've had infectious diseases, and it's a very effective method. That said, it's a very time-intensive set of steps that need to be done with respect to manual and retrospective contact tracing. And in addition, it's very likely that because of how COVID manifests itself, there's going to be lots of asymptomatic transmission because people don't necessarily recognize when they're infected. They may not have any symptoms at all, or they may be infected prior to their recognizing their symptoms. So next slide, John. That's kind of where we were faced with, and I think this is uniform for us throughout our organizations. We started to think about ways in which IT could help to support contact tracing efforts. And what I want to make clear is that none of what you hear today is meant to replace the manual contact tracing efforts that are already in place, but rather just to give an additional tool for those folks who are doing the contact tracing to enable them to be a bit more efficient and to have a more robust way of ensuring that they get all of the potential contacts that a person might have had. We've been prioritizing initially at Boston Children's patient to employee potential exposures, but as you'll see in the presentation, we've now shifted a little bit and are starting to look in addition at employee to employee potential exposures. Next slide, John. So I think this is where, John, I was going to hand it to you, right? Yeah. Why don't you go ahead and start to talk folks through what we've been doing and then what we're about to do.
Great. Thanks, Dan. And I thought with your years of experience, it would have been more than 35 combined.
Ouch. Ouch.
Ouch. All right. So from I couldn't help myself. So from a patient to employee contact tracing perspective, we had developed an infectious disease tracking application. Frankly, it's a REDCap database in part, and in part a custom developed app where if you have a patient who is a known positive or a suspected positive COVID patient, we have a computer outside the room with a badge reader, and you tap your badge on your way in. And so you're essentially registering yourself as going into that patient room and being part of that potential exposure. And we combine that with some data warehouse reports that we have. We can look at the logs of the EMR and say who has touched the patient chart. And of course, we know that that's imprecise because people who touch the chart may not have gone in the room, and there are people who have gone in the room who have not touched the patient chart. But between those two methods, we try to get around the employee exposure to positive patients. And so that's where we started, and that's where we prioritized our work initially to ensure that we had some sort of methodology to log personnel who could have been exposed to a COVID patient. But as Dan alluded to, we've deployed that, and that's been active for a while in our institution, and we have turned to working on employee-to-employee contact tracing. And just to give you a sense, per unit time, employees are interacting with employees much more than they are with patients, and so per unit time, it's important and a priority for us to try and deploy tools that will help to understand that interaction and potentially be able to augment what infection prevention and control does if there's an exposure from one employee to another. And so we started working on this Bluetooth application, and it is a fork of the MIT Safe Paths app, which is actually a fork of the Safe Path app, which is a fork of Safe Paths and then COVID Safe Paths, and then we forked the COVID Safe Path app. And it is the 180-degree opposite of what COVID Safe Paths app is. So that app is a privacy-focused app, meaning that if you put this app on your phone, based on the app itself, it's going to be very anonymous and private. But we've actually taken the opposite point of view and really made this an identified version of that COVID Safe Paths app. And the point of it is to log device-to-device interaction. It measures the signal strength of that interaction and the time the amount of time that interaction occurred. And it uses, instead of a randomly generated number, it uses the device serial number in the case of an Android device and the device name for an iOS device. And the app is very simple. What you see on the screen here, this schema here is really all that the app collects and all that the app uploads. So it's serial number of the device, serial number of the device that it felt, start time, end time, and RSSI, which is the signal strength. And that's all that gets uploaded to the server. And to be clear, this is a server that's not a server that's out of our network. This is actually an internal server. And the app is created in such a way that it only logs these interactions if you're on campus. So it has to be able to ping the database server, and only if it can feel the database server does it start to record for 15 minutes and then upload the information. And then it repeats that cycle. So where we're at today is this Bluetooth app is ready to go. We've tested it on a bunch of our non-production devices that we have in-house. We have a shared device that's an Android-based device that we've deployed to there are 2,000 devices deployed across the institution. The app is publicly available on the Google Play Store right now. And again, it's configured only to work if you're on the Children's Hospital Network. And then we're working through the many canards that are Apple to get it finally available for iOS. We have a working version, and it's just a matter of getting it out there on the Play Store. So that's great. That app is really useful, and it helps us better define interactions between devices and thus personnel. But that doesn't give us geolocation in the hospital, and so we use the information from our Wi-Fi network, and we're a Cisco client, to now take those interactions and place them in space. So we use our Wi-Fi network to locate those interactions in space. So while it's not as precise and not as refined as the Bluetooth interaction, it does give us unit level information. In fact, it does give us XY coordinates of any personnel. And so what we do is we use both the Wi-Fi data and the Bluetooth data together to match interactions between personnel in space. And so with our shared devices, we're really able we have analytics and everything defined on both sides to be able to get the logs from the Bluetooth interaction, from the Wi-Fi data, strength and duration, devices in space, and be able to ask the question for any given personnel logged into a particular shared device. Where are they in space, and who do they interact with over time, and actually past in time? And so we're not going to just put this on the shared devices. We're planning on putting this on personal devices as well. And we have the analytics ready to go for the Bluetooth side, because it's the same analytics. There's a little more hopping to do in order to be able to identify personal devices in space in our organization. And we can talk a little bit more about that in a minute, about what we have to do to get some of the data from the personal devices. And the idea is to also offer this app freely to our all of our employees. They would download it, and they would download it because they want to make sure to record interactions with other personnel in the organization in case one of those other personnel do become positive, or also if they become positive, to be able to let their fellow colleagues know and be able to let an infection prevention and control let their colleagues know that they turned positive and might have exposed them. So here's conceptually what we're trying to do with all this data. We're able to, so if you can imagine, this is a floor, and I'm just sort of panning this around for a second. This is a given floor, and these are some employees, and this is a patient here. We can, have employees come in on the ground floor here. We can trace them up through the elevator and them interacting on a given floor here, and we can sort of say, okay, how of the interactions that are occurred on that floor, how many of them, given the signal strength and the duration and time, do we need to contact because they may have been exposed to another individual who was COVID positive. And that's the animation again. Okay, so you've heard about 4 different data sources that we have, and we really can mix and match and weight the various data sources together depending on what we're doing, whether we're doing patient to staff kind of analytics or staff to staff interaction. You can use these 4 sources of information together and bring them together to say, okay, here are the group of personnel that need to be contacted for surveying and contact tracing. And for us at Children's, if we say, look, you've been exposed, whether or not you've been masked or not, what IPC does is send a survey out to that employee saying, how you feeling? And then at the end of the day, they get another survey, how you feeling? And they do that for 14 days. So it's 28 surveys that we sort of monitor our staff for in case they develop symptoms as well. And so, this approach of having these 4 data sources together and using them in combination allows us to sort of blend sensitivity and specificity to a point where we're able to get to a refined list of personnel to be contacted for surveying and tracing. And so here's how this all comes together. This is the 5-step reality here. So you have a COVID positive personnel that's identified by OCOTH. So they say, hey, I've turned positive. I have symptoms. You get a given date for that onset of symptoms. What IPC will come to us and say, this employee, this date and time, and you look back, X number of days, and based on both the Wi-Fi data and the Bluetooth data, we can then get to a group of personnel that might have been exposed to that employee. We give those ID numbers back to IPC, and they go and survey. They use the methodology they have today to go and survey those patients for 14 days and interview them, make sure that they don't turn positive as well, or test them along the way. And so, there's this feedback loop because this is not perfect system at all. Bluetooth interactions can happen through walls, and Bluetooth interactions can happen through doors. So it's there's refinement that goes on in an ongoing conversation between us and the IPC to correctly and refine the signal strength and duration of interaction. Okay, I think we're almost at time here, Dan, but we're rolling. The raw strategy is obviously this comes with lots of HR conversations and legal conversations and communication conversations. And so that's where we're at right now between legal and HR and public affairs and emergency management to deploy this. We are essentially ready to roll out this Bluetooth app to all the shared devices now, waiting on some final policy refinement on the HR side. And then we'll learn from that, and then we're going to make the app available to everyone on all devices across the institution. And that's where we're heading very soon.
Yeah, so I can, yeah, keep going, John. This is what I was just going to talk about.
Yeah. So obviously, there's lots of privacy concerns. There's this concern around employee tracking of location. Once you're on Boston Children's campus and you connect your own personal device to the Wi-Fi network, there is no expectation of privacy anymore. And so that is already sort of a priority, the case. And so we're just taking advantage of the data that's already there. And from the Bluetooth perspective, this does not locate people in space. It's just the relative proximity. And there are opt-out mechanisms, right? You don't have to download the app. You don't have to put your device on the Wi-Fi network. Even if you do both of those things, the app itself allows you to click stop if you want to stop broadcasting your Bluetooth signal if you want to. And we're not going to keep this data forever. There's only a limited subset of personnel who will have access to this information. And our HR policies are pretty clear that this data is not going to be used for anything else other than contact tracing. We're not going to use this for disciplinary action or any other sort of location kind of issue things. This is just specifically for contact tracing. I'm sure this will generate a ton of questions, and so Dan and I are happy to take your questions, and make sure to download the new song that Dan has out there at the Defective Records. So
leave that for the end, John. But no, just if you want to flip back for a slide, and this is probably a great point of discussion for the breakout groups. But I'm sure many of you have seen some of the public offerings, from the Apples and Googles of the world. I saw an article in the New York Times a day or two ago about this broad category of things. Some states are deploying apps along these lines. But I think one important difference between what we've rolled out or about to roll out compared to those other efforts is just this localization, if you will, and the fact that This is not a, you know, a system that's going to send your data to Google or Apple or to a state. This is a Boston Children's centric app. And our hope is that people's level of comfort at using the app and knowing that their privacy is not going to be intruded upon and the data used for nefarious purposes, our hope is that that's going to make the difference so that people will be more comfortable with it. And frankly, because this is a platform that only works when an employee is on the job, on site, that it will allow us to be a bit firmer in not necessarily making this an optional tool and rather having this be a mandated tool. So lots of good discussion together with our legal and compliance and HR folks on our side. I'm sure many of you can imagine similar conversations for each of you in your places as well. So
yeah, we're really trying to position this as a tool that Boston Children's has developed and is making available to its employees to help protect them. So this is really positioning the tool as a way Boston Children's is trying to help you, help protect you.
Yeah. So Jonathan, with that, Jonathan Fritz, that's what we had for presentation. If you want to do your magic to do the breakouts, that's where we're at.
Sounds good. Thank you very much, Dan and John. Really appreciate it. And, you know, Dan, we did have a live performance by CT Lin on the ukulele last week. Are you sure that we're not going to be able to get a live DJ performance from you today?
Well, you're not, the honorarium that you're offering, Jonathan, is not high enough, first of all. No, but
good.
what I can share and what John Bickel's showing on screen here is some of you know that I have an alter ego as a techno musician, and I also run a small record label. And as fate has it, today is a release date for a new record on our label. The label is called Defective Records, which is a catchy name, and you can see it there. And so if you navigate to that link, you too can buy a copy, either digital or vinyl, because I know all of you are old school. You can buy a copy of the vinyl. Beautiful package, gatefold sleeve, double LP, just waiting for you to purchase.
Excellent. Look forward to listening to that, Dan. Welcome back, everyone, from the virtual roundtable discussions. I joined one of them, and we had some pretty interesting conversation around contact tracing and innovation and predictive analytics and things that you know, you folks have been creatively solving problems around, especially related to COVID. One of the things I wanted to mention is that now we're going to go into Q&A, and we are recording this again. You know, I'm going to ask a question to Dan and John. You know, obviously your organization has a history of innovation, has you know, some foundation that has been built over time. But as far as you know, not necessarily recommendations, but words of advice to your peers that are on here as far as sustaining innovation. Are there internal partners, allies, folks that you can help carry or suggest carry the message? Because what you have been enacting here, you know, there's a lot of nimbleness and you know, to creatively solve this problem. But you know, once COVID goes away, and you know, folks may revert to kind of the old ways of thinking, you know, we want to be able to sustain innovations and be able to help continue solve those problems. So Dan, and then maybe John, if you want to talk to that, and folks, if you want to add questions into the chat window to ask Dan and John, please do that.
Yeah, you know, I go back to when we sort of formalized our innovation efforts many years ago, and the way they started, I think, was probably instrumental in the question that you're asking, Jonathan, which was that we started not by looking externally to see what new vendor or new shiny startup or whatever was doing. And we more so focused on soliciting ideas that came from inside our organization, because for all of us, we all got smart people that are working, you know, in care settings, and inevitably they are going to have some good ideas. And so if you can just carve out a teeny bit of technical resource time and maybe some oversight, you know, around business development or project development kinds of, you know, resources for those folks, and bring one or two of those things to life, it starts to feed on itself, right? Because then people see, oh, you know, Johnny got his idea rolled out into an app and we're using it in the endocrine clinic, and Sally's doing the same thing, and that, and you know, you start to generate some excitement. And then from an administrative point of view, if people see that, gosh, there's good ideas that are emerging from our own teams, then that makes lobbying for additional resources a little bit easier, and then, you know, potentially allows you to establish a more formal innovation team. That's how I'd answer, and honestly, that's how we started and how we eventually grew our program.
Yeah, I've just been lucky enough to, you know, Dan's let me have enough rope to go and, you know, get this going. So, you know, Dan is in the institution have created a culture of wanting to hear about good ideas, and I thought this was worthy of at least talking about it. And Dan's been kind enough to let me leap here.
So John, there's obviously a culture of innovation that Dan talked about and had been built over time, and that has helped or enabled you to realize, I've got an idea and I can bring this forth and it's going to be well received. Yeah. Any other kind of thoughts around like your perspective or the process that you went through in saying, yeah, I think this is something that we should pursue, and how you went about really saying, or putting together kind of the proposal for Dan and maybe others to consider?
I don't know, Dan, did I put a proposal together? I think I did.
This was COVID time. John, this was an email. John said, I want to do this. And I said, what? And then he came back with another email with a little bit more info. And then it was just like, okay, do it. You know, that was one of the nice things about COVID, is that a lot of the usual bureaucracy and committees and approval processes got thrown out the window.
Yeah, never let a good crisis go to waste. This has been my motto, not just for this app, but for a whole other bunch of stuff that I'm doing at the hospital.
Hey, Jonathan, we had one detailed question come up in our group that I didn't have the full answer for, and I'm hoping that John Bickel knows. John, the question was around, first of all, how big of a lift was it to branch the MIT code to work on, and basically to get this up and running for our team? But second, with respect to Bluetooth and battery life, how are you dealing with that to make sure that, you know, the battery doesn't drain in an hour?
Yeah, I mean, this is using BLE, so it's actually not too bad of a drain on the batteries that we know of so far. Our shared devices have not needed to be recharged more frequently than we would have thought, but I with an asterisk that, come back to me once I put devices, and let me tell you that in after that. In terms of forking the code, you know, the COVID SafePass data or code is freely available off of GitHub, so we just forked it and started our own branch. So we're not intending to submit it back to COVID SafePass. We've gone too far away from MIT's intention of that app to go back there. So we'll keep it on our own copy moving forward. I've had actually conversations with the head of COVID SafePass, and there's a possibility we might be able to bring this back together, but it's really the they're the 180-degree opposite side of their code. So it's hard to imagine people trusting one app that either has like, phase 1 or phase 2, essentially I'm either completely anonymous or completely identified. It's hard to imagine people would accept one app to do both.
So we've got just a couple minutes left. Richard asked a question. Are there any plans to share internal contact tracing with any of the governmental efforts on the topic?
So far, no. And again, this is, we thought this was important from that privacy point of view. We really want to make the point to our staff that this data is solely going to be used by Boston Children's. Now, I will say that, we're already sharing positive statistics with the government. And, I don't know if there's any plans to send identified data. I gotta think not still. So we really have taken the stance that this is a Boston Children's centric thing. And hopefully that will help us with acceptance by the staff and accepting what we're trying to do and trust us.
Excellent. Well, in closing out, just wanted to thank Dan and John again. We really appreciate the presentation, the discussion, obviously the breakout rooms and Q&A. For those that are attending, as well as those that are listening on demand, we'll send out a survey and really appreciate your feedback. We'd like to get information from you as to whether this program, which is a new one, meets your needs, or if it doesn't. Please let us know. Gold star to Praveen Chopra for guessing that my virtual background is Bunker Hill in the back. So gold star to him for today. We've got a couple of upcoming events. Monday is going to be our 14th Innovation Beyond the Edge and the last of this first season. Brian Herrick, the CIO of Cambridge Health Alliance. And then June 24th, we have a new program called InnoCast, where it's a partnership between a health system and a startup. Aaron Meary, CIO of UT Health Austin, is going to be leading that presentation, 10 a.m. CT on June 24th. And just wanted to thank Denise and Phillips once again for our series sponsorship, as well as sponsorship for and partnership for today. So last but not least, really thank you for your time. We're happy you could join us, and have a wonderful day and be well.